The success of kidney transplantation to treat patients with end-stage kidney disease is compromised by the occurrence of T-cell and antibody-mediated rejection, as well as other inflammatory mechanisms mediating graft injury. Detection of these graft injuries currently requires a graft biopsy for diagnosis. Moreover, intra-observer variation in pathology biopsy reads complicates the interpretation and the ability to distinguish the underlying mechanism of graft injury that could be used to direct the most efficacious treatment strategy. These problems could be eliminated with the development and validation of non-invasive biomarkers capable of detecting ongoing kidney graft injury and differentiating the cause of the injury. As graft immune cells infiltrate the graft, and there are damaged kidney cells that are shed into the urine as a consequence of kidney graft inflammation, RNA isolated from the urine could be used to identify transcript markers that are associated with the injury. We and other investigators have previously used a pre-amplification enhanced quantitative polymerase chain reaction of urine RNA to identify transcripts associated with imminent or ongoing acute T-cell mediated rejection. However, these approaches are hindered by the limited number of probes that have to be used for the assay, the requirement for pre-amplification of target transcripts that can potentially lead to errors in detection, the amount of work and time to perform the assay, and the observation that currently identified targets using this approach, while being sensitive to detect rejection, lack specificity for the cause of that graft injury. In an effort to increase the range and strength of urine RNA transcript profiling to detect and differentiate subtypes of ongoing kidney graft injury, we employed a new state-of-the-art molecular detection technology, the NanoString nCounter platform, as a multiplex approach to interrogate RNA isolated from the urine of kidney transplant patients. This approach provides quantitative transcript level data on up to 800 gene targets, does not include a pre-amplification step, and is amenable to detecting transcripts in samples with partially degraded RNA, which increases the efficacy when using urine RNA to devise the test. We have identified a urinary gene expression profile, actually a 10 gene signature, that can detect acute T-cell mediated rejection with high accuracy and sensitivity and distinguish the injury from non-injured kidney grafts. We are now extending this approach to develop diagnostic gene signatures to detect graft injury caused by BK virus nephropathy and graft-reactive antibody. This approach will provide a non-invasive multiplex test that simply requires kidney transplant patients to provide a urine sample and can be performed quickly and cheaply to detect and distinguish different mechanisms of kidney graft injury that can in turn be used to optimize therapy. Importantly, kidney graft biopsies cannot be performed routinely, whereas this non-invasive test will be used on a regular basis, for example, every 4 to 6 months to monitor the status of the kidney graft. The license for our work has been recently purchased by a biotechnology company, and we are working with their teams to complete development of this test to get it into clinical use as quickly as possible. Finally, I'd like to thank CCF Innovations for taking this concept and helping us expedite progress in getting it into the clinic where it can be used to help kidney transplant patients. Thank you.